Good morning, and thank you for having me. My name is Matt Sullivan. I'm the Associate Chief Medical Informatics Officer at Atrium Health, and I'm really great to be able to talk with you all this morning at the Southern California HIMSS chapter. And let's, without much further ado, let's begin by trying to get my slides to kick off and to share the screen. So I will do that momentarily here. Let's see. You would think after 7 months in isolation that it would be relatively simple, but no, not so much. This is highly successful. So the topic of my talk is creating a new world for now and beyond, and I wanted to spend a little bit of time talking to you about that we've done within our own environment, as many of you all have. I talk about some of the lessons learned, but not necessarily as they apply only to COVID, that I think we're all becoming very COVID weary, but really to sort of think about and contemplate how they affect medicine and the delivery of healthcare as we move into a new era, in the post-COVID era, and specifically around how that affected our informatics division and the work that we do to support our physicians and our nurses in doing everything that all of our healthcare agencies do. Quick intro as to who we are and what Atrium Health. I think a few of you know who we are, but we're a fairly large healthcare system in the Southeast. We have well over 40 hospitals, well over 900 care locations, around 3,000 providers, and more than 60,000 of our teammates, including all of our ancillary clinicians and our nurses, which as organizations, that comprises the vast majority of what we do. We're the second largest public not-for-profit healthcare system in the nation, and have about 12.5 million patient encounters every year for our collective group. And additionally, that spans a fair bit of geography, as is shown here. We're primarily governed and headquartered out of Charlotte, North Carolina, so we're in the South, as the map shows. Presence in North Carolina, Georgia, South Carolina, and really grateful to be part of that team. It's been a long-standing journey for our healthcare system. This is the building of the original Charlotte Memorial Hospital, and it still is actually part of the foundation of our main academic center based in the center of Charlotte, which is larger than this picture demonstrates. It's a fairly big campus, but more importantly, we have a tremendous amount of encounters every day. We serve a tremendous number of people, and what drives me to work is really the impact that our informatics division has on this care delivery. In addition, we have a tremendous amount of uncompensated care and benefit that we provide every day to our community at large. So we really are community partners, and we see ourselves as very much integrated into the regions that we serve. And that's really embodied in our mission, which is to improve health, elevate hope, and advance healing for all. And our vision is to be the first and best choice for care for the people in our region. And I think that's really true for the work that we do every day, and certainly is true for the work that we've done in COVID. Now, here's the obligatory headshot. I'm going to go ahead and sprinkle in some ridiculous. This is me. I'm the Associate CMIO. I've been an emergency physician for coming up on 25 years. I've been at the same location, did my residency here at Carolinas Medical Center, and a fellowship and board certified in emergency medicine informatics, and that's probably all you need to know about me. These are the objectives, which I put up here as obligatory. Really, we're going to try to take some of the real world challenges that we encountered. I'm going to talk about those and then hopefully get some back and forth Q&A that will follow. I think that the impact that COVID has had has been longstanding and will remain with us in certain aspects. Certainly, hopefully the good ones and not the bad ones. It's been a fairly tiring 8 months of work, now coming up on 9 or 10 months of work very shortly. with a tremendous loss for the nation, and we're working our way through it. And I think we've all done a very admirable job in the healthcare industry. We're continuing to rise to the challenge, and hopefully we'll understand a little bit more as we talk around how new technology plays a role and what it has for both the COVID and the post-COVID era, and what we've been able to really learn how to do in the process of walking through some of these challenges. So the really lofty goals here, away from the baseline objectives, is I'm going to give you some of our struggles and talk very openly. Hopefully that's a shared experience with you. I don't think this has been particularly easy for anybody. Having said that, once we relate those experiences, I'm going to try in each one of those cases to give you sort of the impact and the outcome as to how I believe that it affects our current evolution and our future of healthcare. And if we're lucky, we'll hopefully have some things to contemplate as the talk goes on. It won't be terribly boring, and we'll roll right into a question and answer right after this. And I'm going to sprinkle some ridiculous memes here because, why not? This is the COVID times we're all living vicariously, and sharing some humor is probably helpful to move us along. So I think it goes without saying that this time has been tremendously chaotic. This has been hard for everybody, and certainly if you've dialed into this conference, you have probably struggled mightily as the rest of us have. I think that we can develop the success stories from that struggle, in so much that a tremendous amount of focus now on our governance internally. I'll hear in just a few minutes about some of the informatics principles that we were really able to underscore, and people finally got it, I think, which was great for us. Many hospitals and healthcare systems stand up an emergency operations center for things such as hurricanes, but we've had one now going since the beginning of March, late February, as it relates to COVID operations, and how that group interfaces with our informatics team has changed, and I think has changed for the better. We'll talk a little bit about that. We'll talk about how to manage remotely and what we did to manage a large team that quickly exited. And we'll talk a little bit about some challenges that we have had around keeping the team and building the team, and how do you do that in a remote setting. And then I'll try to reflect and relate some of this back to what I think will be changes in healthcare. I think I will try to do that humbly. I don't think that my opinion is any different than anybody else. That could be what I think. And so let's start with some of the governance. And we had the added advantage of being right in the middle of changing our governance. And for an IT department, for data and analytics, and for information services, that's a struggle I think we all reinvent every few years. We go back and rebuild and retool our governance. We were doing so really in anticipation of changing EMR vendors. We're going through a large transition period from one major vendor to another major vendor, and that's very entertaining. It came at just the right time. COVID came and really helped shape some of the governance, not so much in how you set up a governance, but really the impact and the long-term impact for the outcome on healthcare is really around the users and how they understand what our governance is doing and how they can interface with our informatics services. So that goes all the way up, from the CMO and the CNOs of our organization, physician group leaders, administrative leaders, all of whom are now a part of our governance and really are ingrained, not only are they at the table to make these decisions, but really that changed in COVID, and they needed us to really action on things very, very quickly. And I think it's further strengthened the idea that an informatics department or an informatics and analytics services group really is part and parcel of the operations of the healthcare organization. And if that was in any way under question, as it has in some healthcare institutions that I've been able to talk to, I think COVID helped us solidify that we are right there at the table to help. And I'll talk a little bit more in each one of the instances about of the things that we did, about how that came about and how I think that plays a role here. So I believe that we're coming out with really now a new end user understanding of why we have the governance and how to access the governance, how to move projects through so that they aren't at the last minute asking for resources, which I think will help us very much in the future. The first is workarounds related to change. There's nothing, no better word that I would describe than change. And I think it's really the exercise is how to not be in crisis mode all the time. I think every hospital and every healthcare system has the ability to operate in a fire drill. But that's really not an effective way to operate. I don't think any of us would agree to that. And I've listed a few things here that I really think affected every human being that has touched COVID in any way. The laboratory testing variability with the number of tests that came online rapidly in the spring really caused us to think twice about how we're going to manage that. The supply constraints that continue to plague us today in some areas of the country with reagent, with swabs, with which tests are online, how do we get cartridges for the new tests, and who's going to control that, all the way down to which areas were open relative to PPE in some extreme. And those supply chain interaction is really driven off of data. And so when the information and analytics teams were at the table for those kind of conversations, it was really nice to be able to build a nimble environment so that people can have quick conversations. And I really think that plus a rapid redeployment of staff was a challenge. We took a lot of people out of the healthcare and sent them home, including at-risk nurses, and had to redeploy them to different regions. We closed offices for a while, and I think that was the case with lots of folks, but it really wasn't the desire. Our desire was to deliver healthcare and to be in the office and to manage patients effectively. And then there was the pendulum swung very quickly back to a rapid return to normal. And that's what people wanted to do, and that's what we were challenged to try to address and respond to. We start to use, if you've read General McChrystal's book, Team of Teams, the Team of Teams approach is to really be very nimble and to not micromanage and to make sure that the people at the level of the decisions of the work are able to make decisions rapidly. And so we've been able to do that. And that went for us all the way down to the level of analysts and director level folks who were really, hands-on, knowledgeable about the problems, knowledgeable about the solutions, and we're able and empowered to make those quick decisions and then report that back up without fear. And that was really quite good. Partnering that with a redeployment of people to a remote work environment really was a little bit chaotic in the beginning, but for those people that embraced that, it really allowed us to make some rapid decision making, and it's worked out incredibly well for all the rest of the work in the non-COVID environment that we've done. Those people that were part of our COVID response are actually also the same people that are doing work in our EMRs and work with our research teams and work in our data analytics team. And they're able now to really have this ongoing back and forth conversation with leaders to keep them informed, but they're able to make decisions. They feel good about the jobs that they're doing and their impact on healthcare delivered. And I think that's a great thing. It took a high level of connectivity. Thankfully, we were in the process of transitioning our communication to Microsoft Teams, and I think that was really incredible to see how quickly the number of teams stood up. And I think it was really timed well, but the team stood up all over, and people were able to quickly message and quickly get in communication nimbly to achieve the approach. And there was a little bit of informality with that, and I think that was good. I don't think anything stodgy and meeting driven was always the right answer, particularly in the nimble mode. And I think we did a great job there. That internal communications was really good. We had a very high level of internal communications, and so much so that in the beginning, I myself in March and April just thinking, how am I going to manage all of these inputs? It was Teams, it was text messages, it was emails, it was phone calls just constantly coming in. But it was that level of connectivity that allowed us to be really rapid and really iterative in our work. It was also clear to us that, and it remains that way now, that there was a clear distinction in the types of meetings that folks were having. It was very clear that people were uninterested in report out meetings, that those meetings were really just waste of time. People really were interested in goal-driven, decision-making meetings. We've seen a tremendous decrease in the number of meetings for this. Nobody was building a series of slide decks anymore. We shortened our number of meetings, the timing of our meetings, down to what were previously hour meetings are now all 45 minutes, and hopefully down to 30 minutes. And quick touch points that may have been 30 minutes or going to lunch with someone now are 15-minute phone calls. And I think that has increased our cover a lot of topics and actually increased our productivity tremendously, and it will continue to increase productivity long after COVID. The downside on that, and the true impact that we're still struggling with, is it extended our working hours, so much so that I always worry that people are working now instead of 9. They're working more of a 7 A to 7 p.m. 5-day-a-week schedule, and that's tough. So we have to work on that. External communications is the same outside of your own informatics or IAS or whatever your department is called. We chose that to sort of make patient-facing stuff a primary driver for what we were doing, and that was really good. So with regard to all of the pieces of communication that we drive out, that's the primary driver. It was very much the case for COVID. We had a lot of COVID information that had to be delivered to the community based on our internet presence, as well as our patient portal presence. We also drove a lot of patient-facing stuff out in discharge instructions. Cycles that we had many times, particularly in the early portion of COVID, where things were changing rapidly, solidified that communication externally to the patients and also within the various groups that weren't inside of IAS, whether that's ID and infection prevention or whether that's part of our primary care division, to make sure that everybody was in contact. And that physician communication cycle really increased a lot, to the point where we were driving out near daily emails. And previously, physicians don't particularly like to get emails from hospital administrators or information services or anybody, frankly, when they're busy. And now people were clamoring for information. And so we capitalized on that. And I've seen our communication cycles increase and be more valuable as a result of COVID. And I think that's going to persist long past where we are in this COVID cycle. Additionally, I think one of the other impacts is that now we've all strengthened our partnership with our marketing division. And, a lot of people have various and sundry feelings about what marketing does. And I now know what the value is in far better of a way than I did before COVID. And so I think that's another impact that we should not ignore. From a knowledge transfer, my graphics weren't great here. I'm sorry. My knowledge transfer here is that at one point we had a realization sort of in the early part of April that there were 4 or 5 people that really knew how everything connected, and that there was a sudden need for some redundancy. So if we have 4 or 5 people that know how all of the sequences and all the interfaces are wired up to deliver the right kind of education to physicians, all the way through the ordering process, to the lab process, to resulting and reporting process, we recognize there was a need for redundancy. So in addition to the adage, never attend the meeting alone, I think one of the impacts that we have seen now is that, one, as I mentioned in the last few slides, a ton of communication increasing in a good way, a lot of redundancy of human beings in meetings. So we would have the analysts in the as sort of a leader in the meeting. And that was quite nice, because sometimes I would sit in on meetings and I'd get the interface, wouldn't, and hear their work and understand a little bit more about them. So it's actually, for me at least, improved my job satisfaction. There were 1 million Teams channels. This is just our internal IAS working group for COVID, and you can see the number of Teams channels that we stood up so that everybody could watch what was going on. You didn't actually have to be in every meeting. Sort of, at the end of the day, go back and sift through the various messages to understand all of the work that's going on, so that if there was something that piqued your interest or caught your eye that you needed to understand, You could drill in right there under the channel and get the expert who was watching that channel give you the feedback you needed. So it was really great for a knowledge transfer functionality, and I think we capitalized that. On the back meme that I put on there was a poor woman who's doing way too many things, and I think all of us sort of felt that way, and still to some degree do, that we're doing a lot of things all the time. But instead of having one person doing all of them, it's really nice now to sort of plan to make sure that everybody is connected and that more than one person knows what's going on. It helps you actually take vacation and take time off. So as a case example for that, I'd like to talk a little bit about the lab and the COVID orders. I mean, we had no testing for COVID, and then all of a sudden everybody came out of the woodwork to have a test for COVID. Some of them vetted and some of them were from national vendors. But regardless, the interesting part was not only did we as a healthcare and information services have to wire up all of the different tests, but within each test there were some subtleties about the tests that we applied differently to different patient populations, and that we had sort of an on-off switch based on what the supply chain looked like. Adding that to the various ask on order entry modifications that the government wanted us to submit with each one of our testing made the testing and ordering process incredibly complicated for an end user. And so our outcome from there is really to begin a process and to continue the process of trying to make sure that all of the user interface work is really user-centric. So it was, as an aside, I had an interesting call, another issue, and there was a CMIO from a large healthcare system that said that they had stood up, sort of in a bragging way, 50 orders for COVID. And I thought, well, I didn't know there were 50 tests, but it wasn't that, as they had set up their options so that for each individual circumstance that all of the stuff was pre-filled out. Well, we started to think about that, about, do our physicians really want to type COVID and see 50 options? And so we actually had only a couple, sort of an inpatient and outpatient. We were able to sort of build our work on the back end, and that required a tremendous amount of teamwork with our lab personnel, because they were actually switching tests on the back end. But our front-end users just knew that they were ordering the test, and they just knew why they were ordering it. It made it really fast and really easy for them. And I think that lowered the level of anxiety around COVID and lowered sort of the work effort on the front end. Now, on the back end, we were really concerned about how our lab team is working. And so continue to iterate to try to make that user-centric approach, but to make it seamlessly throughout the entire spectrum of the ordering process as easy as we can for people throughout the process. And I think that's going to persist. I think we're sort of carrying that message forward as we begin to think about how to bring on new point of care testing and new antigen testing, and that's going to carry forward. Certainly our partnership with our lab has never been stronger. And in fact, I just in the middle of this, it was beeping a minute ago, I apologize, but my phone is beeping because the head of the lab just called on in the middle of my talk. And that's the back and forth communication that I think is essential to our ongoing success well in the post-COVID era. And to be honest with you, we've been talking about this forever, but a vastly simplified EHR interface is really what our providers want in the first place. I think that's a positive that's come out of our work here. I think there are many folks in the nation that set up Emergency Operations Center. Certainly we have one, and it ranges from hurricanes to now pandemics. Typically the CMIO or the CIO would sit in on the emergency operations meeting and be a conduit for whatever might come up. And that became sort of a very top-down approach. We've now engaged many layers of our IAS teams to be part of the various emergency operations. For an organization of our size, we have various meetings that have to be attended to, and we overlay a couple of people to attend each one. And that's been really good, because now multiple layers within our information systems group understand what the operational needs are for the organization. And again, it also keeps one person, namely the CMIO or CIO, from having to manage all of those various meetings, whether it's reintroduction of work, keeping the workplace safe, supply chain issues, testing environment, anything that we've stood up around home health and hospital at home. it's really been good to sort of allow our many teammates in IAS to sort of attend these meetings and really spread the work out nicely and keep coordinating the communication side behind the scenes. And I think we'll continue that long after this pandemic is over. Additionally, it was very nice to have some of our information services people really be the lead in some of the information and reporting out to the larger medical group. Numbers of our team have been on the system-wide calls, and they're getting familiarity with speaking in public and being able to deliver information that otherwise we hadn't had in the past. And I think if that continues, that will be a really good thing moving on. I talked a little bit about how much physicians hated emails, and I'll briefly go over this again. Physicians don't particularly want to hear much when they're working busy clinically a ton. And certainly with the increased pressures of the pandemic, that didn't. However, there was a real need for information and a real need to make sure that you were safe as a provider, and that your team was safe, and that your office was safe, and that your patients were. And so people really wanted it. So we ended up with a daily leadership call, and that would never have been feasible pre-pandemic world, but certainly it's persisted now for a number of months. Now the frequency's gone down to a couple times a week, but they have tolerated now daily emails, especially with COVID-19 and operations. But those emails are ongoing now, and it's allowed our leadership team to be able to vastly disseminate pieces of information that previously would have been deleted or gone into a folder through an automated rule. People are reading them. People are becoming more engaged, and I have seen in our pandemic era, and I hope this continues long after, a deep physician engagement by giving them information that they need and weeding some of the other information out, and at times making it somewhat humorous with the memes and the silliness of what goes on by the pandemic work. So how have we been able to sort of equate some of this to a change in actual medical practice? Well, there's a few things I want to highlight, and I don't want to spend a ton of time on them because I think all of us are doing this across the nation. Able to talk a little bit about and work up a fairly aggressive virtual hospital situation for Atrium Health. And this is a slide I took from one of our first talks back in March. But we were planning for about 100% additional bed capacity, and the idea of doing that was really daunting, as it was for all of us. So we built a hospital at home program for 2 levels of care with observational patients that just needed the touch point on a daily basis, that had some daily preventative screening questions, as well as an acute hospital where we actually had paramedics in the home with a virtual connectivity back to a hospitalist who managed their care aggressively when they otherwise would have been in the hospital bed. And we've been able to really take care of a large number of people at home throughout the pandemic, and also hopefully keep our hospitals as empty as we can to preserve capacity for the regular ongoing operations of our healthcare agency. So that's really what we've been successful doing, and it's really decreased the spread. We were able to use our analytics team to help bring the clinical team together using a series of scorings that we had known were successful for pneumonia. We built a scoring stratification tool to really help drive the right patients to the right location and get patients who were otherwise really amenable to care outside of the hospital back to home with the right support that they needed. And you can imagine an analytics PhD scientist coming to the table with this. It was really great conversation. The clinicians were heavily engaged, and we were able to disseminate this across our entire organization in the Charlotte region really rapidly and respond very, very well. And each of you on this call knows that at each one of these steps, people were asking for various parts of technology, and we'll get into that in a minute. But eventually, we developed a very nice symbiosis of patients moving in and out of the hospital in a seamless way, all while, and that connectivity, our information team was really one of the underpinnings and the backbones to support. And part of that support is a lot of the things that they needed were technology driven, and that's not a shock to anybody on this call. how we went through two-way patient communication, particularly when we had visitor restrictions. The number of people that came out of the woodwork to provide software for us to do symptom monitoring was overwhelming. And how do we get real-time alerting from home? What kind of technology do we need for patient monitoring? And I'll talk about the remote patient monitoring in a minute. How do we do education? How do we do reminders? Where does the patient portal interface? How do we get people on the internet to connect quickly back to care when they need it through chatbots? These were all of the technology problems that frankly we struggled with before COVID, that we're now forced to rapidly manage. And case tracking still, I believe, is a very difficult concept for many of us in the country. And each one of these has allowed us to refine the way that we operate. The remote patient monitoring is worth talking about. As I saw it, everybody outside of healthcare had something to sell us, and everybody inside, all of our divisions, wanted us to buy something, and it became just a little bit of nuts and chaos. I would say I've probably taken close to 100 vendor calls in the last 10 months easily, and some of them were fantastic, as you all know, and some of them were really intriguing. At one point, I was on a phone call with a vendor for remote patient monitoring who said, when asked about a question, the answer was, "Yes, I think we're going to have that. My brother is coding that today, and we'll have something to look at tomorrow." And so it ranged from the sublime to the ridiculous. But the end point and the outcome from this that I think is long lasting post-COVID is that we developed a fairly strong relationship with our innovation team. We developed a better set of rigorous questions to ask, what is really the problem to solve? And early on in the process, when 5 or 6 people were pinging us continuously to buy a very expensive product, the question is, well, does it have a pulse ox? And the answer was, in all cases, early on, no. And so if we're managing a respiratory disease, we need some indicator of how the respiratory disease is progressing. And we were able to sort of hold off spending a bunch of money on something that helped the problem to solve. And I think that kind of rigor and that kind of continuous conversation and with our medical group teams has really solidified how we're going to operate in the post-pandemic world. And that sort of takes us to the build versus buy. It's an age-old question. Do we buy it from someone or do we build it internally? And this is not a conversation that a lot of people can have. But I think we're fortunate to be a large organization, and we do have a tremendous talent, depth, and finances to help with some of the building questions. And some of it is easy. In the bottom left corner here, we did build a number of things inside of our EMR to help catalog, screen, capture data, and all of that work is pretty routine and managed by all of us. But on the right side was our approach to how do we get our teammates quickly screened. And so we actually did build, using simple tools, Microsoft Form, to gather information about our doctors or our APPs or whoever was sick or felt like they were sick, give them all the appropriate screening questions, determine if they were a candidate for COVID testing, and then behind the scenes match their data to our human resources database, pass that information to our scheduling, Epic scheduling, and then pass that across to our Cerner clinical EMR to actually order the test for them and send them an email back that says, you're scheduled for a test here, go get your test, here's the time. And the patient, from the moment they filled the form out until the moment that the testing was available, somewhere in the 15 to 20 minute range if done correctly. And so that was able to really help us unburden a lot of the teammate management that was really troubling in the early part of the COVID. But it helped us understand the build versus buy. And it was clearly probably faster to build this than it was to buy or enter into a relationship with a vendor to then build it. And that has then given us some time frame to evaluate each one of the various vendors to figure out if they were the right partner for us, not just for managing one piece of this like COVID, but long term to see if downstream, when things go back to normal, is this the right vendor partner for us to manage heart failure or diabetes or some other healthcare issue. And so I think the answer, as it turns out, is probably okay to do both. It's not a build versus buy, it's a which one do you do and in what time frame. And I think that's changed a little bit about how we approach some of the problems that come up in healthcare. So I'm hopeful that that persists in a post-pandemic world. Again, the value proposition of the virtual hospital is also not limited only to COVID. Despite the fact that this slide was made during a COVID-19 pandemic, is this slide applies to pandemic and post-pandemic environment for healthcare. We did do it for surge. However, maybe there is a high value to this. Certainly, if we can devise a value proposition that lowers healthcare costs and delivers the same quality outcomes, I think most of us would agree that that's a really good thing. And the question is, do the patients like it? Do the patients appreciate it? And I think the crisis of COVID allowed us to get into that environment and iterate and understand some of those answers. And the answer has been that, yes, the patients do appreciate being at home. They do appreciate connectivity. And some of the things that we had long held were potential problems, such as technology and the age of our patients. Really turned out that that's not really always the case. There are a lot of elderly patients who are very comfortable with technology, and despite also having medical illness. Research, for those of you who are in research environments, I think that this is also strengthened in a post-pandemic world. You know, originally the IS group is always the afterthought. You know, someone fills out a grant, they sign a letter of intent, and then all of a sudden they turn around and say, oh, I need some stuff out of the EMR, or I need data. And the perception of a lot of people was not just how do you get data out of the system, but who do you know that can call someone to ask for a favor, and that's really not the way it was ever designed. It's not the way it works, but that's sort of the perception. In the for a lot of people wanting to study and research COVID-19, we developed a research consortium, and it became sort of a funnel of all the research that would go in, and a great idea sharing, and it allowed us then to have somebody from our IT division at the table to help coordinate both with requests for things to be built and extracted out of the EMR, but also the full data extraction for the purposes of research. And I think if we continue in that way, I think we're going to be much better off than we were in the pre-COVID way. And so I think that's an excellent benefit that we have seen in research. I can't really talk about changes in healthcare without referencing remote work. Clearly, we all had a rapid deployment home. We sent about 10,000 people home very quickly in a matter of a couple of days. There was always the clamoring of what kind of stuff can you take. I don't think anybody took their desks, but I know a lot of people wanted to take the chairs and certainly the computers. And we had to devise processes for that. But what it's done for us in the planning of the post-pandemic phase is, well, why do we need to have people in? What's the value of having this real estate? And so a partnership with our facility management has allowed us to think about all the buildings that we own and all the buildings that we lease, and what is the interval advantage of having people gather? Certainly in a pandemic world, the advantage is there's none. They'll just get sick. But in the post-pandemic age, I'm hopeful that we can save money and use our space in a different way. I certainly had an office. I haven't been back to my office since St. Patrick's Day. So I think that there's probably not a whole lot of value to me having an office. I'm not sure I would have said that a year ago. The second thing that I think has persisted that is really quite good, and I'll talk a little bit here in a minute, is that we've now been asking our teams, since they've gone home, we've been worried about them, we've been pinging them to ask, hey, what do you think about this? Are you engaged? And we've continued to do that on a regular basis so that our teams feel connected to the work that they're doing. And I think that that's strengthened some of our teams. But let's talk a little bit about that. And certainly in the immediate pandemic, when everybody went home, there were some adages. I put some quotes up here. Hey, the people who are working, and if you were relevant before, you became more relevant. And to some degree, the antithesis of that was also true. Those people who probably weren't doing a lot of work faded off. You didn't hear from them very much. If they weren't doing great work before. They certainly, very few of them rose to the challenge during the pandemic. It became hard. And the impact is, I think, going to be longstanding. There was initially some dissatisfaction. I think there's also a high level of burnout for people that are working really hard. But on the flip side, there were a lot of people who really just rose to the challenge, and we've been able to promote people and give them advancement in the company. As a result of the dissatisfaction and the recognition that the work that they were doing wasn't particularly great, we've had a number of people across the organization in our information team resign, and that's difficult because hiring in this age is a little bit perhaps more challenging, but promoting within has worked out very well, and the resignations have been amiable, and we've been able to be nimble and prove to ourselves that even in a remote work situation, the business, as it's always been, continues to be the business, and that restructuring is often good. And I think that we're going to see that continue in the post-pandemic world. Again, in the staff turnover, we don't want to see that happen. It's expensive to retain and recruit good people, and there's a sense of, I'm just done. I hear it a lot. Oh, how are you today? Oh, I'm just done. And I think that comes from a couple of things: working really hard, a little bit of burnout, maybe some lack of engagement. But we've taken all of the things that we've learned from other organizations and worked hard ourselves. We've had our mandatory, time off. We literally have said to people, I'm sorry, this weekend you really can't work. You've got to take 2 days off. Certainly in March and the beginning of April, we were all working nonstop. And we've had the, sort of tried for 12 hours and tried to get it socially through Zoom and have distance meetings. A couple of people that live in Charlotte near me, I've biked over to their house and they've stood on the deck and I've stood in the yard and we've talked about some issues. So we tried to be a little bit innovative there. And I think some of that is going to in the post-pandemic world. We need to be mindful of how much we're working. We need to be mindful of the people around us. We need to be social when it's appropriate and try to be human about the work. And I think that will persist long past COVID. And hopefully eliminate some of the turnovers, or maybe even decrease what would be normal turnover. Well, I've talked now for a while, and I want to make sure that I'm leaving plenty of time for questions. So I'll conclude with this: that obviously in this period, a ton of technology has and the applications have changed in healthcare. Whether that's Teams, whether that's Zoom meetings that have been now the new normal, whether that has been a switch heavily to remote work or engaging in virtual healthcare, which all of us have done. I think it's really strengthened the way that informatics and informaticians work. I think that's given us institutional, really strong underpinnings so that we are both engaged at the table and relevant in the future. And I think that's good for us as information informaticists. I think that the challenges that I presented here are not unique to Atrium. Everybody that's listening to this call has dealt with them. And I think it's given us really great opportunity to change some of the way that we work, some of the way that we communicate, and integrate ourselves in the healthcare systems, as well as really helping us sort of frame the new health post-pandemic world. So with that, I'm going to be online here with you, and I'm happy to answer Q&A. I appreciate the opportunity to speak with you all, and thank you very much.